everyone. Welcome back to the series of lectures in endocrinology. Today we are discussing about the adrenal gland, and amongst the adrenal gland disorders, we are discussing a very important topic, which is your Cushing syndrome. So let's begin. So what exactly is your Cushing syndrome? So Cushing syndrome is a constellation of clinical features that results from chronic exposure to glucocorticoids. So Cushing syndrome is basically a constellation of clinical features that results from chronic exposure to glucocorticoids. Okay, so etiology. Let us look at the etiology of Cushing syndrome. So when it comes to Cushing syndrome, before I go on to your textbook description of Cushing syndrome, what we should know is that in India and in your clinical practice, be very clear about exogenous glucocorticoid use. Okay, so what happens is that in the clinical scenarios that we come across, what happens is that there are many patients who go on taking exogenous steroids. Because steroids have anti-inflammatory action, they may be taking it for pains, they may be taking it for non-specific complaints, they may be taking it for a wide range of conditions, inflammatory disorders and so on and so forth. Right? So many a times, especially in the Indian scenario, glucocorticoids are available over the counter and they are being misused rampantly. So before you go ahead and take a detailed history or before you go ahead and evaluate a patient for Cushing syndrome, always rule out exogenous glucocorticoid use. Always rule out exogenous glucocorticoid use. Take a detailed history about the drugs that they use. Take a detailed history about the drugs that they use of over-the-counter medications, use of Ayurvedic medications sometimes which do have some amount of glucocorticoids in them. Okay, so exogenous steroid use in itself can cause a Cushingoid appearance because of the side effects of steroids. Okay, so when it comes to endogenous causes, of Cushing syndrome, then this is the list that we have to be looking at. Okay, so what are the causes for Cushing syndrome? So Cushing syndrome can be classified as ACTH dependent and ACTH independent Cushing syndrome. So ACTH dependent Cushing's basically means that there is a pituitary cause or ectopic ACTH production. The Cushing syndrome that occurs due to an ACTH producing maybe a pituitary adenoma or a pituitary cause is what we call as Cushing's disease, and this accounts for 75% of your causes for endogenous Cushing syndrome. Okay. Then ectopic ACTH production. Ectopic ACTH production can be due to bronchial carcinoids, pancreatic carcinoids, small cell lung cancer, medullary thyroid CA and pheochromocytoma. So when we talk about ACTH producing or ACTH dependent Cushing syndrome, which accounts for a total of 90% of the endogenous Cushings, it can be because of pituitary adenoma or ectopic ACTH from these various list of cancers. Then ACTH independent Cushing's means that there is cortisol production directly from the adrenals and it's not under the dependence of ACTH. So adrenocortical adenomas or carcinomas, right? Then we have certain rare conditions like pigmented nodular adrenal disease, macronodular adrenal disease, which is very rare, and you have your McCune-Albright syndrome where there is an activating mutation of GNAS. Okay, so what are we looking at? We are looking at Cushing's. Always remember this golden point. Before going and evaluating for endogenous, always rule out exogenous glucocorticoid use. When it comes to endogenous Cushing's, we have ACTH dependent, ACTH independent. ACTH dependent accounts for 90% of the cases where we have an adenoma or ectopic ACTH production. ACTH independent is because the adrenal in itself is producing glucocorticoids in excess because of some hyperplasias or genetic conditions. Okay, so this is about the causes for Cushing syndrome. Now let us look at the clinical features of Cushing syndrome. So what are the clinical features with which a cortisol excess patient can present to you? So first, there will be abnormalities in the body fat. They present with weight gain, central obesity, round face, which we also called as moon face, and there can be excessive fat on the back of the neck, which we call as buffalo hump. So cortisol basically causes redistribution of fat and excessive fat accumulation, resulting in all of this moon face, which is excessive fat in the face. There can be buffalo hump where you have excessive fat in the neck or central obesity as well. Then what happens to the skin? So cortisol use basically causes very thin and brittle skin with easy bruisability. And the most specific sign, many of this weight gain etc. is seen even in metabolic syndrome. It need not always be Cushing's syndrome, right? So if you really have to diagnose clinically whether this can be a Cushing's syndrome, then you look at the presence of broad purple striae. Broad purple striae. So broad purple striae which are more than 1 centimeters in width is more in favor of your Cushing's syndrome. Then there can be acne and hirsutism as well. Very importantly, the skin will be stretched, thin, friable and easy bruisability will be seen. Third, chronic glucocorticoid use can result in osteopenia, osteoporosis, and there is an increased risk of fractures. So if it's an endogenous Cushing, chronic glucocorticoid exposure predisposes them to fractures. Then when it comes to the muscle, it can result in proximal myopathy. It results in proximal myopathy. So how do you identify whether the patient has proximal myopathy? The patient has difficulty in getting up from the sitting position, patient has difficulty in climbing stairs, patient has difficulty in squatting. Okay, so that is about your proximal myopathy. Then cardiovascular system. Now, because your Cushing's syndrome or excessive cortisol can be associated with dyslipidemia, so it can be associated with a higher risk of hypertension, edema and atherosclerosis. Also, we know that whenever glucocorticoid is in excess, it can also act on the mineralocorticoid receptor. So when glucocorticoid is in excess, it can also act on the mineralocorticoid receptor, and so it can have some amount of mineralocorticoid activity as well. So this will result in salt and water retention resulting in edema, and it can also cause accumulation or retention of sodium in water, excretion of potassium which results in hypokalemia. Okay, so this entire manifestation which we are seeing here is because of mineralocorticoid activity. Fine. Next, it can result in glucose intolerance, diabetes, dyslipidemia that we have already seen. Then Cushing syndrome can cause decreased libido in women, amenorrhea, because it inhibits your gonadotropin release. ACTH inhibits gonadotropin release. Because of feedback inhibition, it has some kind of an inhibitory effect on gonadotropins as well. In the central nervous system, it causes irritability, emotional lability, depression, and in fact, sometimes severe cortisol excess can cause acute psychosis as well. It can cause acute psychosis as well. Then, blood and immune system. Chronic glucocorticoid exposure basically is like an immunosuppressant. Okay, so many a times we see that glucocorticoids are being used for autoimmune disorder. Why? Because they have an immunosuppressive property. So they cause an increased susceptibility to infections. And what is the characteristic feature that you find in your CBC? In your CBC, you find eosinopenia. So in your CBC, you find eosinopenia. It also predisposes to a hypercoagulable state with an increased risk of deep vein thrombosis and pulmonary embolism. So there is an increased susceptibility to deep vein thrombosis and pulmonary embolism as well. So this is about the whole clinical features of Cushing's syndrome. So can you see in these images? This is your central obesity. This is central obesity. You can see that the skin is stretched, friable, and this is your purple striae which are more than 1 centimeter wide, and this is again nothing but your different bruising, easy bruisability which is seen in this image. Okay, so this is about the various clinical features. Now let us understand how is ectopic Cushing's syndrome different from your actual original Cushing's syndrome. That means that how is ectopic Cushing's means what? Ectopic ACTH production. So if a patient has ectopic ACTH production versus your pituitary adenoma which is producing ACTH, how is he going to present differently? Now remember that ectopic ACTH production is predominantly due to cancers or malignancies, right? It's predominantly associated with malignancies. It's associated with carcinoid tumors, small cell carcinoma. So how are they going to present? Very, very importantly, they have a rapid onset. They have a very, very rapid onset of symptoms. Very importantly, the other point is that they are more severe. So they have more severe hypertension, more severe and rapid hypokalemia. Okay. So, ectopic ACTH production can cause more activity or mineralocorticoid activation, severe hypertension and severe hypokalemia. Then, ectopic ACTH causes stimulation of what we call as your pro-opiomelanocortin. There is pro-opiomelanocortin stimulation which results in a diffuse hyperpigmentation. There is a diffuse hyperpigmentation. And paradoxically, the Cushing syndrome should be associated with weight gain because this is a malignant process, it is associated with weight loss. So, there can be weight loss as well. So, these are some of the very, very important clinical features which help in you identifying whether this could be an ectopic ACTH production. So, the rapidity of onset, diffuse hyperpigmentation, weight loss, more severe hypertension, hypokalemia is more in favor of ectopic ACTH production. Alright? Okay. Now, let us look at the diagnosis of Cushing syndrome. So, how do you diagnose Cushing syndrome? So, first step, as I had mentioned to you, before diagnosing anyone as Cushing syndrome, which is basically your endogenous Cushing's, always rule out exogenous glucocorticoid use. Right? So, before diagnosing anyone as endogenous Cushing's, always rule out exogenous glucocorticoid use. Fine? So, that will be your first step. That will be your first step. The next test will be your screening test. Okay? So, if there is a clinical suspicion of Cushing's, which is central obesity, proximal myopathy, striae, amenorrhea, hirsutism, hypertension, osteoporosis, then your screening test will be 1. A 24-hour urinary free cortisol excretion which is increased more than 2 times. 24-hour urinary free cortisol excretion which is increased more than 2 times. Then your second screening test is your dexamethasone overnight test. Dexamethasone overnight test. In this, what happens is that we give 1 mg of dexamethasone at 11 p.m. and you check your cortisol at 8 a.m. next day morning. You give 1 mg of dexamethasone at 11 p.m. and you check your cortisol at 8 a.m. in the morning. So, whenever you give dexamethasone, what should happen? Whenever you give glucocorticoid externally, then we know that glucocorticoid just has a feedback inhibition. So, this is going to inhibit what? It is going to inhibit your ACTH and is going to inhibit your CRH. Right? Because of this feedback inhibition, your entire pathway is going to get inhibited. Cortisol should get depressed. So, the ultimate result is that the cortisol level should be low. Okay, because of the feedback. But here, after giving your dexamethasone, the plasma cortisol continues to be elevated at more than 50. Okay, so after giving 1 mg of dexamethasone in the night, when you check your plasma cortisol levels in the morning, it continues to be elevated. That means that what? There is some endogenous production of cortisol. It is not getting affected by your exogenous dexamethasone. The third screening test is your midnight salivary cortisol levels, which are more than 2 times. Okay. Why is it that you do not take a direct blood cortisol level and decide whether if it is elevated, it is directly Cushing's? Why is that so? Because cortisol has a lot of diurnal variability. It has a lot of diurnal variability and it's influenced by a lot of the number of factors. Right? So, that is the reason why you have these screening tests. So, you use a 24-hour urinary free cortisol excretion, midnight salivary cortisol, and we use your overnight dexamethasone suppression test. The fourth test which can be used as a screening test is a low dose DEXA test, where you give dexamethasone 6 hourly for 2 days and then you check your cortisol levels. Then ideally it should have got suppressed, but here the plasma cortisol continues to be high. Okay, what is the dexamethasone dose that is given in your low dose? It is 0.5 mg. So 0.5 mg of dexamethasone is given 6 hourly for 2 days and the cortisol continues to be elevated even after that. Then this is considered to be positive screening test for Cushing's. Okay, clear till here? So, what have we learned? We have learned about the 4 screening tests. 24-hour urinary free cortisol, 1 mg overnight dexamethasone suppression test, 0.5 mg low dose dexa suppression test we give for 6 hourly for 2 days, and we check your midnight salivary cortisol. So, we always have to remember that sometimes you can have false positive tests as despite your screening test. In your screening test, you can have false positivity. So, make sure that they are not on cytochrome P34 inducing drugs like rifampicin. And OCPs, if the patient is on OCPs, then cortisol binding globulin levels will be high. If these are high, then the cortisol levels will also be high. Okay, so be very careful about your interpretation of your screening test. So once this screening test is done, we have to go over and look at your confirmatory tests. Okay, so once this screening test is done, we have to move forward and look at your confirmatory test. And how do we go about? What are the differential diagnoses? Let us look at that. So now you have done your screening test and you have identified that there could be a probable Cushing syndrome. You look at the plasma ACTH. Why? Because you have to know whether this is an ACTH dependent Cushing's or an ACTH independent Cushing's. Okay, fine. So if the ACTH levels are normal or high more than 15, then this is an ACTH dependent Cushing's. ACTH dependent Cushing's, what are the types that we understood? It can be because of pituitary adenoma or ectopic ACTH. So now that you have found that this is an ACTH dependent Cushing, you have to find whether this is a pituitary adenoma or if this is ectopic, right? So the easiest way what you would think is, if it is a pituitary adenoma, do an MRI brain. Do an MRI brain, you will find the adenoma. But it is not so, because MRI brain may not be positive in 40% of the individuals, and that's why you have this long flowchart for diagnosis of Cushing's. Okay? If the MRI pituitary is showing an adenoma, well and good. The next confirmatory test that you will do is a CRH test. CRH is your corticotrophin releasing hormone. So you give 100 microgram IV of CRH, and if you see that the ACTH has increased by more than 40% at 15 minutes or more than 20% of cortisol has increased by more than 20% at 45 minutes. Okay, so you look for your ACTH increase and your cortisol increase after giving CRH. Okay, so after giving CRH, what should have happened? After giving CRH, what is the ideal response? The ideal response is that the ACTH should have increased by more than 40% and your cortisol should have increased by more than 20%. If that happens, if the test is positive, that means that it is a pituitary dependent. That means CRH is stimulating your ACTH to be produced. Well and good. If that response is not there while giving your CRH, that means that your ACTH is not increasing. That means what? Your ACTH is not dependent on the CRH, right? So if your ACTH is not dependent on the CRH, it is not a pituitary cause. CRH test negative means ectopic ACTH production. Okay, so clear till here? So what are we looking at? Let's put this back into perspective. So we are looking at the screening test for Cushing's. We have already seen that. So once you have done your screening test, you're still thinking of Cushing's, you have to find out whether this is ACTH dependent or ACTH independent. So for ACTH dependent Cushing's, ACTH levels are elevated. After that, you have to see whether this is because of pituitary adenoma or ectopic ACTH. So you do your CRH test. In your CRH test, if your ACTH response is there, ACTH is increasing to more than 40% or cortisol is increasing by 20%, that means your ACTH is responsive to CRH. The axis is intact. So that means that the ACTH is from your pituitary itself. If it is not responding, that means what? This ACTH is being produced irrespective of what the axis is doing, what your HP axis is doing. So then CRH test negative is ectopic ACTH. Similarly, we do a high dose dexamethasone suppression test. So here we give 2 mg of dexamethasone. Your low dose is your screening test where you give 0.5 mg. In your high dose dexamethasone suppression test, we give 2 mg for 2 days. And cortisol, what will you expect? It has to get suppressed by more than 50%. So when you give a high dose dexa, even if it is from a pituitary adenoma, it has to get suppressed. That is the basic point. So if it gets suppressed, high dose dexamethasone test is positive and it has got suppressed, then again this is your pituitary adenoma and your HP axis is intact. If your cortisol is not getting suppressed with your high dose dexa, then that means this is ectopic ACTH production. Okay, clear? So your CRH test and your high dose dexamethasone suppression test are used to find out whether this is an ectopic ACTH production or is it because of your pituitary adenoma. The results are equivocal. Despite these two tests, you are not able to find out if this is pituitary adenoma or is this an ectopic ACTH. Then we do something called as an inferior petrosal sinus sampling. Nowadays, we don't do it much because most of the time we get our answers. but you do an IPSS. Okay, so where you do a peripheral ACTH ratio more than 2 at baseline and more than 3 at 2 to 5 minutes after CRH. So what do you do here? Here you basically inject your CRH and you take a sample. You take a sample from your inferior petrosal sinus and you take a sample from your peripheral blood as well. So here you look for the ratio. So petrosal to peripheral ACTH ratio. You take for the petrosal to peripheral ACTH ratio. If that is elevated, then this is more in favor of Cushing's disease. It's more in favor of Cushing's disease. So if your petrosal to peripheral ratio, which is more than 3, more than 2 at baseline, more than 3 to 5 at 2 to 5 minutes after your CRH injection, then this is your pituitary cause. Okay? Fine. If it is negative, then it is ACTH ectopic. Okay? Clear till here? So what all have we looked at? We have looked at ACTH dependent Cushing's. Once you have diagnosed ACTH dependent Cushing's, you have to find out, is this because of ACTH production from the pituitary adenoma or ectopic. So for that you do your CRH test, you do your high dose DEXA test. High dose DEXA, you expect that if it is a pituitary adenoma, it should have got suppressed. Cortisol should have been suppressed by more than 50%. If it is getting suppressed, it's pituitary adenoma. Not getting suppressed, ectopic. In your CRH test, after giving CRH, you would have expected the ACTH levels to have increased. That means that the axis is intact and this is happening due to pituitary adenoma. If it is not happening, then it is independent, it is ectopic. If you get equivocal results, then you do an IPSS where you do an inferior petrosal sinus sampling. Here, after injecting your 100 microgram of CRH IV, you take a petrosal to peripheral ACTH ratio. If that is elevated, then it is pituitary adenoma. If it is not, then it is ectopic ACTH. Clear? So clear till here. Now we will look at how ACTH independent Cushing's, how will you approach it? So if the ACTH levels are low, it is ACTH independent Cushing's. So ACTH independent means what? The Cushing syndrome is because of steroids which are produced from the adrenal itself. So we do a CT of the adrenals, you see if there is a micro or macronodular hyperplasia. If that is so, you go ahead and do a bilateral adrenalectomy. If this is a unilateral adrenal mass like an adenoma, then you do a unilateral adrenalectomy. Okay? So this is very easy, right? How will you treat your pituitary adenoma or your ACTH producing pituitary adenoma? You do a surgery. In your ectopic ACTH, you will have to do a PET CT and try and remove the source, malignancy most often, which is causing your ectopic ACTH production. Okay? Clear? So this is about your approach to Cushing's syndrome. Okay, so we will just revise it once again. Fine. So whenever there is a clinical suspicion of Cushing's, you will have to do the screening test. What are the 4 screening tests? 24-hour urinary cortisol excretion elevated. Then dexamethasone overnight suppression test. 1 mg you give dexa, morning cortisol you check, it should have been suppressed, it is not suppressed. Okay. Midnight salivary cortisol elevated, or your low dose dexa suppression test. Then you look at your ACTH levels, decide if it's ACTH dependent, ACTH independent. ACTH independent is from the adrenal, do a CT adrenal, decide what you want to do. Then if it's an ACTH dependent Cushing's, you will have to do certain confirmatory tests. Do an MRI brain, look for pituitary adenoma. Confirmatory tests include your CRH test and your high dose dexamethasone suppression test. Okay. So how do you differentiate based on that? We have seen. In equivocal results, we do an IPSS and we do give a CRH injection and look for the petrosal to peripheral ACTH ratio. If it is elevated, it is adenoma. If it is not, then it is peripheral. Basically, it helps in localization. Okay. Now let us move on to the treatment of Cushing syndrome. Let us move on to the treatment of Cushing syndrome. So, in an ACTH dependent Cushing's, which basically means that this is an adenoma, then you definitely have to do a surgery. Right? You do a transsphenoidal surgery, which is the best treatment for an ACTH dependent Cushing's. When do you want to do medical therapy? In certain patients where the symptoms are very, very severe, there is hypertension and hypokalemia, which is difficult to treat and it has to be brought under control before surgery, or if it is an adrenal carcinoma, then you have to do medical management. So what are the drugs which are used in the medical management of Cushing's disease or Cushing's syndrome? 1. We have metairopone. So this is a 11-beta hydroxylase enzyme. Then ketoconazole. Ketoconazole is an antifungal, but it also inhibits the adrenal steroidogenesis, especially the early steps. Third drug which can be used is osilodrostat, which is again 11-beta hydroxylase plus aldosterone synthase inhibitor. So this is a newer drug which inhibits both mineralocorticoid and it has 11-beta hydroxylase inhibiting activity as well. Then 4, we have mitotane, which is an adrenolytic agent, and mitotane is commonly used in the management of adrenocortical carcinoma. And the 5th drug is etomidate. Where have you learnt etomidate? We have learnt it in anesthesia. So this is an anesthetic agent which also has 11-beta hydroxylase inhibiting activity, and this is given as an IV drug and it has a faster action. Okay. So this is about the different groups of drugs which can be used in the management of Cushing's syndrome. Okay. The best recovery rate from HPA suppression. So whenever you do a procedure or a surgery, you've removed something, or then you have meddled with your HPA axis. So the best recovery rate from your HPA suppression will be for ectopic Cushing's. So for ectopic Cushing's, then for Cushing's disease, and then for your adrenal Cushing's. So it's for ectopic Cushing's, then your pituitary Cushing's, then for your adrenal Cushing's. Okay, fine. So with this, we have come to the end of our chapter on Cushing's syndrome. Alright. So what all have we learnt till now? We have learnt that Cushing's syndrome is basically a disorder of glucocorticoid excess. The other pearl that you have to remember is always rule out exogenous glucocorticoid use before you go ahead and evaluate for Cushing's. Then many a times there can be clinical syndromes which mimic Cushing's. Always look for purple striae, moon face, buffalo hump, purple striae width more than 1 cm. Then we have looked at the screening test and the confirmatory test for Cushing's and the approach to it. Then we have looked at the drugs which can be used in the management of Cushing's syndrome. Thank you.